Welcome everyone to today's webinar, a follow-up webinar to last month's on deprescribing. Today, we're going to be focusing on deprescribing integration into daily practice. This is the third webinar in the Managing Meds and Minimizing Risk, What You Can Do webinar series. And don't worry if you haven't been able to join the other events, you'll still gain a lot from today's presentation, and you can always go back and watch the other sessions at a later date. Today's webinar is facilitated by the Loop Fall Prevention Community of Practice. My name is Michelle Dukeman, and I am the Knowledge Translation Coordinator for the Fall Prevention Program at Parachute. Before we begin, we'd like to start today's presentation with a land acknowledgement. Today, we respectfully acknowledge the land on which we live and work as the traditional, ancestral, and the unceded territory of the Indigenous people, Canada's First Nation, Inuit, and Métis people, whose presence reaches back to ancestral time. We respect and affirm the inherent rights and title of Indigenous people of Canada and declare our respect of Indigenous elders, past, present, and future. I'd ask that everyone takes a moment to themselves to acknowledge the land where they currently reside. Next, I'll cover a few housekeeping items. During the webinar, if you have questions about the technology, please type them into the chat box. My colleague Marguerite will be monitoring this. If you have questions for our presenters about the content of the webinar, please submit them through the Q&A box. They will be answered at the end of the webinar. You will also only be able to view questions you have asked, not questions posed by other participants. This webinar is being recorded, and a link to the recording will be sent to all participants in about a week, along with the link to the presentation slides. You can view previous webinars simply by heading over to the webinar page on Loop, or you can visit Loop's YouTube channel. I'd like now to introduce our presenters. Denise Beaton, Senior Policy Analyst at the BC Ministry of Health and member of the BC Injury Research and Prevention Unit. Cheryl Sadowski, Professor with the Faculty of Pharmacy and Pharmaceutical Sciences at the University of Alberta and Clinical Pharmacist in the Geriatric Outpatient Clinic at Misericordia Community Hospital. And Pam Howell, Pharmacist with Geri MedRisk and the Briere Continuing Care. You can find a complete bio for our presenters on Loop. Denise is going to start us off with a brief overview of deprescribing from a public health viewpoint, and then Cheryl and Pam will take us through a deeper dive into medication contributions to falls and deprescribing considerations and the interdisciplinary approach and the steps all allied health professionals can take to support medication safety and deprescribing. So without further ado, please take it away, Denise. You may now share your screen.
Great. Thank you, Michelle. Okay, so good morning from Vancouver. Thanks for joining us for this webinar, and thanks to Loop for inviting me to speak on this. So today I'll be discussing the burden of falls in BC, and with a specific focus on older adults and the role of deprescribing in addressing that burden, as well as sharing some preliminary findings from market research into the knowledge, attitudes, and beliefs of older adults and caregivers. And finally, I will provide a brief overview of resources to support deprescribing that are available in BC. So I know everyone who is looped into these webinars knows about the burden of falls among older adults, but I would be remiss if I didn't allocate one slide to share some information about BC specifically. For my colleagues and peers who work in population and public health, but do not work in injury prevention, these numbers are quite shocking. Almost everybody that I speak to either is or knows an older adult who has suffered a fall and sustained mild to severe fall-related injuries. But often this issue is framed as a personal one rather than a public health challenge to be addressed at all levels, including the population systemic level. So we know that falls are the leading cause of injury among older Canadians, with 20 to 30% of older adults experiencing one or more falls each year. The majority of these falls do not result in severe injuries. However, some do. And every 30 minutes in BC, one older adult is hospitalized due to fall-related injuries. Every day, Approximately 3 older adults die due to fall-related injuries, resulting in around 1,000 deaths per year. And in BC, falls among older adults results in an annual total cost, so including cost of deaths, hospitalized treatment, emergency room visits, and permanent disability, of $1.14 billion each year. And while falls among older adults are common, they're not a normal part of aging, and the risk of falls and fall-related injuries can be lowered. So a key way to manage that risk is through medication reviews and deprescribing, as the use of certain medications can increase the risk of falls. Currently in BC, I'm leading the development of the Ministry of Health's Fall and Fall-Related Injury Prevention Strategy, which owes a debt of gratitude to the World Health Organization's Step Safely, strategies for preventing and managing falls across the life course. This was a technical package that was released in April 2021, near my birthday, actually. So I almost felt like it was a personal gift to me, but of course, it's useful for everybody who works in fall prevention across the world. It recommends interventions based on current evidence about what actually works to prevent falls and describes how practical and policy interventions can prevent deaths and injuries across the life course. Among these recommendations is the reduction or withdrawal of psychotropic drugs and rationalization of other medications at a primary care level. So this picture here on the screen is a screenshot from page 93 of the technical document, which summarizes the evidence nicely, so nicely that I will read it verbatim. So it states, review of medications by a doctor or pharmacist regarding fall prevention can reduce the rates of falls and the risk of falling. Health professionals must be made aware of the fall risk associated with polypharmacy, multiple medications, and with psychotropic and other drugs, and fall risk assessment should be built into routine practice. Withdrawal from these medications should be supported by a healthcare provider, such as doctors and community pharmacists. Resources such as the Beers criteria and the screening tool of older persons' prescriptions provide guidance to health professionals about rationalizing potentially harmful medications for older adults. So this recommendation and the evidence base it draws from is the foundation of recommending and supporting medication reviews in BC. So what does that look like in practice? At Finding Balance BC, this is the site which is the base of our Provincial Fall Prevention Month and our Seniors Fall Prevention Awareness Week. But we also use it to disseminate fall prevention information and resources all year round through the website itself and then through social media outreach. So we developed 4 key calls to action for older adults to lower their risk of falls. Physical activity that increases strength and balance, home modifications to remove hazards and install supports, and an annual medication review, as well as an annual optometrist appointment. So we've been sharing these messages for years, but this year we received funding to thoroughly examine the fit of these messages and how they may resonate with older adults and caregivers through engaging in market research. So this brings me to the second part of my presentation. This research is ongoing, and it's a key piece of my PhD research in the School of Population and Public Health at the University of British Columbia, under the guidance of Dr. Ian Pike and Dr. Mariana Brusoni. So I'm currently still analyzing the results of this preliminary research and preparing for the next wave of research, which will start taking place in 2023. And also working on a manuscript for publication. So please keep the information that I'm about to share close to your chest. I'll probably remove these slides when I share the slides for my presentation. But I wanted to give a sneak peek because it's so relevant to what we're discussing today. And I think it's important that we include the views of older adults and caregivers, central even. So what were our objectives in this market research? We had quite a few, but I have featured on this slide the ones that are most relevant to the current presentation. So we sought to assess older adults and caregivers' current understanding of common risk factors for falls, understanding the relative importance, so which one they would rank as most important to reduce that risk, as well as the relationship to falls, how it links up in terms of altering that risk, and the 4 message focus areas from Finding Balance BC as shared on a previous slide: physical activity, vision assessments, home safety modifications, and medication reviews. And then at the end of all of the activities, all of the questions and interviews and discussion, participants were asked to complete the Staying Independent questionnaire, which we generally use, and I'm sure many of you are familiar with, for assessing fall risk. So we wanted to provide context to their answers, but also to have the Staying Independent questionnaire come at the very end of engaging in this research so that it wouldn't color their responses earlier on. And then similarly, caregivers were asked to complete the checklist on behalf of the older adult that they provide care for. So this phase of the research, we partnered with Upwards, which is a market research company, and they engaged older adults and caregivers on our behalf in March of 2022. So who did we talk to this past March? So we wanted to have a representative sample of the population in this first phase of research. We were looking for around 40 participants. We ended up having 37, 26 of whom were older adults and 11 of whom were caregivers. There was a range of ages. Most participants were female. There was a good geographical spread across the 5 regional health authorities in BC. About half of the older adults lived alone and the other half did not. 8 older adults did not take any medications while the remaining 18 did. And 1 older adult was taking 15 different types of medications, 4 used mobility aids, and 15 had experienced a fall since turning 65. The caregivers were mostly aged 50 to 59. Similarly female, a similar geographic spread across the province. They provided care for an older adult who generally did not live alone, and they had a close relationship with the older adult that they provided care for. And the majority of the older adults that caregivers provided care for were age 75 and above. And this was intentional. We wanted to have some representation of the older age ranges, but we're finding it difficult recruiting participants through the means of working with this market research company. And so this was a useful way to have that represented even further within our preliminary research. So a very brief overview of some findings. When asked about the ways in which older adults would reduce their risk of falls, or how caregivers would support the older adults they provided care for in reducing their risk of falls, unaided, so meaning not prompted by a researcher, and not prompted in terms of speaking about specific ways, just asking them, what would you do? And prior to being provided any material from Finding Balance BC to review, most said that they would change their behavior or encourage the older adult to change their behavior by exhibiting more caution when outside their home, such as avoiding curbs, looking for easier routes to walk with fewer hazards, walking carefully or slowly, and avoiding slippery or icy areas. So this aligns with the research literature. Everyone is at risk of falls, you, me, everyone. For adults, our risk of falls is mainly due to extrinsic factors, so the hazards and the environment that we are in. I fell last year while I was running due to tripping on an uneven sidewalk. Scraped up my hands, but just sort of brushed it off and continued on my way. 9 times out of 10, after tripping, I have the strength and balance to put out my other foot and stop the fall before hitting the ground. For an older adult, those environmental hazards such as uneven sidewalks still exist, but the fall risk is increased due to intrinsic factors. However, we see in this research and in the research literature that many older adults still focus on the extrinsic factors and cite behavior to mitigate those factors, being more careful, being more aware. And then in order, so home safety improvements was mentioned, but less often than, being more careful. And hardly after that, physical activity was the most common thing to be mentioned, but once again, considerably less often than being more careful. And hardly any older adults or caregivers, like just maybe one or two, connected the idea of medication side effects or vision issues as a risk factor for falls, or even that managing that risk would reduce risk of falls. So here's a clear opportunity to improve the content and reach of our messaging at Finding Balance BC, and lots more work to be done. I wanted to include this quote from one of our older adult participants. I think medications are a scary thing, and I'm on some, but I know a lot of people have had a lot of side effects. I didn't realize they were side effects. I just thought it was part of the aging process. And so the aging process came up a lot in this research. On one hand, people who had experienced falls said that they hadn't recognized that their risk of falls was increasing because the aging process happened so slowly. And it was only after having a fall did they think, oh, if indeed they did think, I should do something different. And generally that something different was being more careful. And I also thought this was interesting too, just to show that when talking about side effects that increase the risk of falls, sometimes older adults may not attribute those side effects to their medication potentially, but they may just think that it's part of the aging process. So on to an overview of resources in BC. This is going to be a very brief snapshot. So earlier in this year, I took part in a series of 3 loop webinar sessions regarding clinical practice guidelines. And I presented on the clinical practice guideline that we released here in BC in September 2021. Fall prevention, risk assessment, and management for community dwelling older adults. It's available on the BC Guidelines website. There's a separate appendix on medication review, and the suggested management is to consider withdrawing or minimizing the use of psychoactive medications, cardiovascular medications, sedatives, or medications with anticholinergic side effects. I think I pronounced that wrong. The other presenters can correct me. As well, to educate patients on increased risk of hemorrhage with anticoagulant and antiplatelet use, and advise to watch for new symptoms if patients fall. And so there's a whole suite of resources and appendices in this guideline. If you're curious, I urge you to go to BC Guidelines, or you can hit that archive webinar button on Loop and watch the webinars if you would like something in the background when you're folding laundry. As mentioned, Finding Balance BC has information on medication and the risk of falls for older adults, with the call to action being to request a medication review from a doctor or a pharmacist. And then we also have a page for healthcare practitioners, which of course links to the BC guideline, but it also has a handout created by the BC Injury Research and Prevention Unit, the BC Pharmacy Association, and the BC Centre for Disease Control, which provides guidance for assessment of patient risk and examples of drugs that can increase the risk of falling or of a serious outcome if a fall occurs. And then at Doctors of BC, they were a partner in creating the clinical practice guideline. One of their main focuses of late is frailty. And so in terms of supporting deprescribing in 2020, they had a doc talk. So this is their usual series of talks around reducing risk of medications for older adults. It's called Addressing Polypharmacy, New Habits for Effective Deprescribing. And it was created by the Shared Care Committee's Polypharmacy Risk Reduction Initiative, featuring Dr. Mark Laurie, a family physician in Penticton with extensive experience in polypharmacy. It's a 20-minute video. I can pop the link to all of these in the chat box after my presentation. And it just goes over the habits and strategies adopted by Dr. Laurie over the years to help mitigate the well-known risks of polypharmacy, confusion, delirium, falls, and other negative consequences. And then finally, there's some very exciting work happening currently with the Ministry of Health and the BC Pharmacy Association. So in June of this year, the BC Ministry of Health engaged the BC Pharmacy Association and their members to conduct a survey of pharmacists to gain insight into how to proceed with a major redesign of the current medication review service model. So this redesign will heavily feature guidance and support for deprescribing for patients over 65. As the BC Pharmacy Association Board Director member, Greg Wheeler, stated, the current standardized practice model in BC, it can be formatted to work well in a variety of diverse environments, but the original medication review services program that's currently used, it was not created to properly support comprehensive medication management services in communities. So we now have an opportunity to change the program to support the beyond dispensing services that community pharmacists are willing and able to perform. And a key goal for community pharmacists is to provide comprehensive medication management to all patients in the province, allowing for community pharmacists to work at the full scope of their practice and improve job satisfaction. So I'm sorry that I don't have more information about this. The results of the survey have not yet been shared, but they have released a white paper on community pharmacist collaboration with physicians and primary care clinics. So I'm excited to see how this work develops and aligns with the public health fall prevention projects underway. So thank you very much. And I will turn it over to my fellow presenters.
Okay, well, good morning, good afternoon to some of you. I will set up to share my slides, and please advise if there's something that is awry. All right. Well, I am glad to be presenting to you from Edmonton, and I'm excited to be talking about falls and risks. I want to start by just disclosing that I do work with the Canadian Deprescribing Network. I've done a sabbatical with CADN, and that also I'm incorporating material from CADN to advise regarding medication safety reduction. And I also have some funding from the pharmaceutical industry, which is a topic not related to our talk today. These are the 4 areas I want to address today. So in the next few minutes, I hope to highlight a few points about medications, their risk, and how we can reduce that risk. We know that falls are a syndrome, so there's multiple risk factors, there's many components that we have to consider, and medications are just one component. There's many different reasons why people are falling, and there's all sorts of interventions that we can do, but today we're focusing on one intervention, on medications. And within the guidelines, it's a fairly busy algorithm, but I have highlighted that medications do have their own focus. So they are a priority within guidelines, highlighting that there are certain medications that should be addressed, that should be targeted when we talk about falls. Well, you've heard in the previous 2 presentations in this series that medications actually have quite a few positive effects, but also many side effects. And in older adults, especially, these side effects can be quite impairing. So they don't just cause a little bit of dizziness, they actually can cause so much effect on balance and dizziness and vision that someone could end up falling. So we sometimes underestimate the side effects. And even in the first presentation, you heard people thought, well, it's just part of being older, it's part of aging, and it's not. It's often because of the medications that people are taking. We also know that as people age, their bodies change, and so they are not able to remove medications from their system very efficiently. They tend to keep those medications in their bodies for a little bit longer, and so those side effects will last for a longer time, or they will have a more severe presentation of those side effects. Overall, older adults are more sensitive to medication, so even a dose of a medication they have taken for many years, now as their bodies have aged a little bit more, they are now too sensitive to that medication. So even long-standing medications should be reviewed because people's bodies are changing and their conditions are changing. Well, we don't just have a problem in Canada with medication burden, we have a global problem with medications, to the point that the World Health Organization is concerned about how much harm is happening. It used to be more of a Western approach to just prescribe medication. When someone has a concern, whatever it is, we prescribe a medication, and yet this is becoming the way of the world. Whenever there's a concern, someone gets a prescription for a medication rather than other interventions that might help their condition even more and help them in a safer way. So we know medication errors are happening. We have polypharmacy, which is excessive medication use, and particularly older adults are noted in this report internationally as having so much medication burden and so much harm that we need more research and we need more intervention in this area. I won't go through all of the literature. We have over 40 years of evidence that medications are associated with fall risk. We almost don't need more studies. We have enough studies. We have over 100 studies that show medications increase fall risk. We know which medications they are, and we know that there's things that we can do about that. One of the first steps, as Denise has already pointed out, is talking about reviewing your medications. Go through the list. Are you taking too many? Do you still need them? We know that people who are on more medications have a higher risk for falling. So that's the first approach. I want to highlight some, so we're not switching here. I want to highlight that there's types of medications that are problematic as well. And so we have medications that are considered high risk. So I've highlighted those in red, high risk medications for causing falls. So opium alkaloids, this would be like morphine, hydromorphone, and at the bottom, it's at the bottom of the list, but in the top 10 for medications prescribed to older Canadians are benzodiazepines or sedatives or sleeping pills. The medications I have in black on this list, they're in the top 10. So the first medication, almost half of seniors are receiving cholesterol medicine. And the second most common is what we call a proton pump inhibitor. So this is a medicine that reduces acid. These top two medications are not associated with increasing your risk of falling. I just want to highlight where these medications fall. So they're the most common, not increased risk, but the medications in orange or yellow here, these have some evidence that they might increase risk. And the ones in red, we have more evidence that they increase risk. So you can see out of the top 10 medications used by seniors in Canada, 7 of the top 10 increase risk for falling. So we should discuss some of those. This is a review of other reviews. So I mentioned we have over 100 studies in the literature telling us which medications cause falls and how much they contribute to falls. So this is 4 different studies that have synthesized that evidence. So each column is one research study where they've pulled together groups of different articles. What is consistent across almost every study that has ever been done with what we call psychotropic medications, so something that is used like a sedative drug, an antidepressant drug, an antipsychotic drug, these medications almost 100% of the time are associated with increasing falls. So it increases the risk. And you can see this is consistent for each drug class and for each study. So to give you a bit of a sense of that, we have a lot of use of these medications. Again, sleeping pills, benzodiazepines are in the top 10. So thinking about how much benefit do they have? This is a summary graphic from the Canadian Deprescribing Network highlighting that yes, they have a little bit of benefit. You might fall asleep about 14 minutes faster, but you do have an increase in falls. So 50% higher odds and twice the number of hip fractures versus people who do not take these medications. And so it's important. Yes, there's benefits to medicines, but there's also potential harms. I'll also point out that Health Canada actually has fairly strict and pretty transparent guidance on how long to use these medications. So this is a medicine called Zopiclone. It's a medicine that we've had on the market for many years. It's used for sleep, and it's in the province I'm in Alberta. It's one of the most common medicines used. It's paid for by the public health system, so seniors are able to get this medication covered. And we see patients using it, older adults using it for months and years. Health Canada had originally approved it only for 7 to 10 days. So we have to remind people that using sleeping pills is meant to be a very brief intervention. And then other issues for what is affecting your sleep need to be addressed. Unfortunately, this guidance, 7 to 10 days, is ignored often by health professionals and by patients, and it's continued for far too long. So this is resulting in reports such as from the Canadian Institute of Health Information, highlighting things like benzodiazepines and other psychotropic medications as being a great risk, and we should be specifically targeting those. In Canada, we have resources like Choosing Wisely, which prioritizes interventions that we do that aren't helping people anymore, and we should reconsider them. So with Choosing Wisely Canada, they've specifically highlighted, do not use benzodiazepines. And then you can see 3 of the other interventions they recommend relate to medications as well, including number 4 for antipsychotics. This is international across the US as well. Choosing Wisely in the States also recommends against benzodiazepines. This is a study, a review from a little while ago, 20 years ago, but it highlights again that stopping psychotropic medications reduces risk for falls. So this should be our priority. I'll mention briefly a few of the other classes of medicine. So in the top 10, older adults are receiving opium alkaloids, so that would be like morphine. And the evidence on this is a little bit more controversial. So we had a previous presentation in this series on pain treatment. And if we look at some of these medications, not every study points in the same direction. And part of the rationale for that is sometimes when we treat pain, people are more mobile and they're able to walk more naturally, their gait is normal, and they're able to function better. And so by walking normally, that might not lead to a fall. So we have to balance, there's some benefit in treating pain, but there also could be some risk for some people if they have a lot of dizziness or sedation from these medications. So not as much of a risk as the sleeping medications or psychotropic medications, but there's still a potential risk here. And then finally, cardiovascular medicines, a slight pattern telling us that there might be an increased risk. So we also want to review, it's important to consider that there's benefits with cardiovascular medicine. So people are able to have reduced risk of having a stroke or a heart attack, or it's managing their heart failure, but there is a slight risk. And so we would also consider these, but again, lower risk than with psychotropic medications. So overall, I want to point out that medications are not the only contributor, but they're often the easiest to manage, or one of the places where we should start first in reducing risk. I'll just highlight a few resources before I hand over to Pam to talk about how to use these resources. There are international guides, such as from Scotland, on how to reduce polypharmacy, starting with what are essential medicines? What do you absolutely need? Do patients really, really need that sleeping pill? Hopefully not. There's other interventions that are actually superior. When we look at other resources, the Canadian Deprescribing Network, there's resources specifically for the public, really worded appropriately and including the evidence as well, and then resources tailored for health professionals to work on that together. All sorts of other tailored resources such as medications and falls, you'll see here in the top left, coming from the Canadian Deprescribing Network. Other resources such as Sleep Well and Choosing Wisely on how to reduce medication burden. And then also stories are very powerful. And so this is something that's from the Canadian Deprescribing Network, highlighting how people can actually have good sleep without more medications. And then we have algorithms, tools that we can hand out to people and use ourselves, such as a tapering schedule for reducing sleeping medications. And so I want to emphasize again, medications can be quite burdensome. They have benefit, but also increase risk. Our top priority is always stopping sedative hypnotic medicines, and there are a number of resources. So with that, I will hand over to Pam. So thank you for your time.
Thank you very much, Cheryl. So just to kind of complete the last part of it, we are going to kind of continue with the idea of how are we going to all kind of contribute to this. So I know that, from my perspective, I've been very lucky to see that this is, deprescribing is really a team effort. And so I'm hoping to highlight that with the rest of this presentation. And so disclosures, I am affiliated with GeriaMedRisk and Briere Continuing Care. And I also wanted to point out the fact that I want to acknowledge the support and guidance from the Briere Deprescribing Guidelines research team that I had the great opportunity to work with over the last few years. And so some of this content is thanks to them as well. And so a lot of the times, my first question that I get from people that aren't prescribers is, well, I'm not a doctor or a pharmacist. So, why is deprescribing important to me? How can I actually help with it? And thankfully, my opportunities, whether it's been with the deprescribing research, whether it's been my work on the inpatient unit side at Briere Continuing Care or with GeriaMedRisk, has really showed me that interdisciplinary care is key to supporting medication management and supporting patients to make sure that things are done properly and as well are successful on the long run. So hopefully I'll be able to tell everybody that, yes, you do have a role in all of this. And so the three key points that I wanted to kind of review over the next few minutes is the fact that you can support patients and caregivers by offering things like encouraging those discussions about medications and increasing their drug knowledge, by implementing strategies to improve adherence, and also providing those non-drug approaches that many of your expertise can leverage. And so that opportunity number one is really to start the conversation. Both Cheryl and Denise have highlighted the fact that there's, a lot of information out there that is available for patients, but a lot of the times it's not being used properly, or that they aren't even aware of the fact that they could utilize that or be part of that. So I think as an allied health professional, when you're face-to-face with that person, if you're noticing that there could be medication issues, or you have identified that they are on medications that could be of a high risk, then I think it's our opportunity to be able to have that discussion or start opening up those discussions. Keeping in mind that the approach is really key. A lot of the times patients may actually be hesitant to have those discussions because of the fact that they've got a limited awareness of their role in the circle of care. So many times they don't realize that they could actually express their goals of medication therapy, like how aggressive do I want to be? Is this drug really important to me? A lot of the times they don't realize that they should be reporting side effects that they think that they're having with medications, or maybe don't associate their drugs with side effects, has been pointed out with Denise. As well, sometimes they may have little interest to actively participate. So they feel like maybe the doctor knows best and they don't want to question the authority. Their medication knowledge or health literacy may actually also be quite low. They don't even know what questions to ask about their medications, or what is appropriate for them to know. And a lot of the times patients may actually have experiences with conflicting messages about their medications. So it could be the fact that they were never told their medications could be bad for them, or that they've never been told about stopping medications. They've always started medications, or prescribing is always the presentation whenever they've talked about symptoms. So a lot of resources that Cheryl has already presented also look at kind of helping engage those patients a little bit more. And a couple of them here are from the Institute of Self-Medication Practices about their 5 questions to maybe ask, or even from the deprescribing.org website, as far as, helping patients feel more comfortable about talking about their medications. As far as offering patient-focused education materials, so there is evidence actually to support the fact that, planting that seed and providing the opportunity for patients to reflect on this information that we're providing them could actually improve deprescribing efforts. So in 2014, the Empower trial identified that just by providing education on the risks of sedatives actually resulted in a higher percentage of participants discontinuing or reducing drug doses versus those that didn't receive that kind of information. So as healthcare providers, we can actually direct patients to these kinds of things, offering them to potentially circle back if they have questions, or encouraging them to actually discuss those questions or concerns with their general practitioners. The second opportunity I wanted to really highlight is the fact that we could actually support safe medication practices as well. So some of those side effects or things that can happen with medications and related falls is the fact that unfortunately the patients may not be taking their medications properly. So maybe they have continued on with things that they shouldn't be, or there could be drug interactions that they're not aware of. So I think being aware of those adherence kind of implications are important with when you're reviewing medications, or when you're in their patients' homes, seeing that they've got cupboards full of medications, or they're not taking things properly, maybe starting and stopping or missing doses. And so knowing about the fact that there's intentional versus unintentional adherence. And so that kind of means is the fact that though most people have unintentional non-adherence, where they're, really want to try to make sure that they take their medications properly, but maybe have other limitations, whether it's cognitive or physical. There are others that actually decide they don't want to take their medications because of the fact that they feel there are side effects, or they don't think that they're working. So getting that kind of information can really help direct what kind of changes might need to happen, or whether there is opportunities to deprescribe certain medications. As well, blister pack limitations do exist. So everyone thinks that putting medications in blister packs will solve the world's problems. Unfortunately, that's not the case. And in practice, what I've really found is sometimes things like physical or dexterity issues happen. Just because you put them in a blister pack doesn't mean that a person can actually punch them out, or that they're actually willing to put them in their mouth and take them. As well, we also find that does tend to limit the knowledge that patients have about their medications. So sometimes when they're put in blister packs, people or clinicians tend to tell patients less and less about the changes that are happening, or why they're being prescribed certain things. And patients themselves may actually be less and less inclined to ask about those questions than they might if they're actually getting them from vials, or if they're the ones responsible with putting them out for themselves during the day. I think we have an opportunity as well to encourage patients to keep track of those as needed medications. So in the situations of pain, if they are taking those high risk medications like morphine or hydromorphone, then making sure that the patients are realizing how much are they actually taking in a day. And when are they taking them, and why are they taking them? Because that could be important in trying to track whether they're related to any kind of side effects, or actually looking at improvements as well as their pain improves. Maybe we can start backing off on some of those medications. Swallowing issues is also something that can actually increase the risk for side effects or falls with medications, because sometimes if things are being crushed or chewed unintentionally, then they can actually cause differentiations in absorption or things, the way that the patients will process those medications. So if that kind of information is told to you, then it's good for them to, for that information to be provided to the pharmacist or the family doctor. I think encouraging accurate record keeping is also important, so that in that way, at least when a clinician does ask, well, why are you taking this medication, and what are you taking, or when they're doing a medication review, then the most pertinent information is kept and actually shared with that primary care provider. So there's a lot of different ways patients can do that, or that you can direct them to. There is an app through the Institute of Safe Medication Practices if you have some tech-savvy patients or family caregivers, or just even writing things down and including details like who started it, when, what kind of side effects were you told to monitor for, when is follow-up happening. So then that way, at least it's something that can be kept as a diary and a good record of what's worked and what hasn't worked. The third opportunity I wanted to talk to about is leveraging your expertise. I think all allied healthcare providers have that opportunity to maybe, offer services or offer patients and caregivers support throughout the deprescribing process, whether it's the initial assessments or whether it's in monitoring and helping follow up. Non-pharmacological strategies is that first key one, and that could be anything from a physiotherapist, kind of looking at strengthening and balance exercises, so that way maybe pain medications can be reduced, to even things like a social worker who knows about cognitive behavioral therapy to help support deprescribing of sedatives or benzodiazepines if they're being used for insomnia. Looking at adherence strategies. So if you're noticing that it's, patients may need reminders, or whether there's, kind of gadgets that you can offer them, or even looking at the fact that if there's pill burden or polypharmacy, then maybe, directing them to their community pharmacist to help mitigate some of those things. Helping to monitor with improvements for adverse events with medication changes, so that it could include the fact that, if you are implementing non-pharmacological strategies, looking at their PRN usage or as needed usage of their pain medications. And seeing if there's, tracked changes, encouraging patients to say, hey, listen, you know what, your exercises are working and now you're using less medications and you're not falling as much. And relaying that information back to the primary care provider is also a useful trick or tip that I often encourage allied health to do. Connecting them with other allied health professionals. So kind of knowing who your colleagues are. For instance, in the inpatient side, I was very, very lucky to have a close relationship with my occupational therapist. And every time she did a home assessment, she did a cupboard clean out for me. And she'd bring in those bags and bags of medications that patients sometimes, collect at home for me to be able to go through things and do a thorough medication review. So building those collaborations and relationships with patients and their other allied health care professionals is very important. And knowing about the local resources that you might have. So those specialized geriatric services, I think, are sometimes key when you have complex patients or complex polypharmacy issues. From an Ontario perspective, there are many regional geriatric programs where, pharmacists are part of the team and do thorough medication reviews, whether it's through a day hospital or a falls program. And as well, we do have e-consult services as well that allied healthcare professionals can direct clinicians to, and that includes as well Geri MedRisk, which I'm a part of. In closing, just to kind of loop back and summarize, I think the three webinars that have happened over the last few months. What does deprescribing look like in your practice? And I think that reflection is hopefully going to kind of include, if you are dealing with patients with pain or polypharmacy or on anticholinergic medications, what are those next steps that maybe you can do to look into what kind of resources there are out there that you can offer patients in the future, or what kind of expertise might you be able to offer to be able to support those patients? And so that being said, I will open up the next kind of thing to any questions or anything like that, Michelle.
Awesome. Thank you, Denise, Pam, and Cheryl. That was a really fantastic presentation. I loved how applicable it was, and it was a great tie-up for the past three webinars in the series. I will say that we have a couple of questions in the Q&A box, and I'm just going to share my screen now to get your contact information up for folks in case they want to take it down. I'll go over a couple of housekeeping items before we move on to the questions. This is just a quick reminder that the next webinar in the series is on February 7th, where Jana McNulty and Jackie Alves will help us learn about the complexity and biopsychological nature of the pain experience and the need for multifaceted pain management approaches. I did drop the link to register in the chat, and I will be sending it also out via email along with the recording of today's webinar, and you'll receive that in a few days. When the webinar has ended, you will be redirected to Zoom and invited to participate in a short evaluation survey. So please do fill that out for us. It's really helpful and will help us to continuously improve these presentations for you. So I'm going to move on to the Q&As now. So thank you, Cheryl. I saw that you had a written answer for the question about thyroid meds. So I'll just read that out loud quickly in case anyone else had a similar question. But someone asked whether thyroid medications are have a fall risk associated with them. But the research does not show that thyroid medicines are a risk for falls if the medication is used at a dose that normalizes your blood level of thyroid is not a risk. The slide was had both the top 10 classes of medications and had 7 classes that are associated with increased risk of falls. And there was 3 that are not associated. And so thyroid medicines were in that 3 that are not associated. So just to clarify in case anyone else had that question. But the next question that I'll move on to is, they write, I always find it interesting that people feel benzodiazepines are associated with a higher fall risk than antidepressants, but is actually the opposite, close, but still. Why so little effort on antidepressant deprescribing? Wondering if any of our presenters have thoughts on that. I will also note that someone in the chat made a good point about costs, and that medications are often covered by universal healthcare, and then things like antidepressants are paid out of pocket. So some considerations there, but I'll pass it over to our presenters in case they have anything to comment on this topic.
Yeah, this is actually a very good question. I wish we had a bit more time to talk about the psychotropic medications, but on the slides, you'll see there is a risk for sleeping medicines, antidepressant medicines, and antipsychotic medicines. We approach them, and they're all very similar. So Barb Farrell is correct that they all increase risk of falls. They're associated with falls, they're associated with falling and breaking your hip, so injurious falls. The concern with some of the other classes of medicine other than the sleeping pills is that there may actually be more benefit with those classes of medicine, and it's harder to treat with other forms of therapy. So if it's just a sleep problem, people are having difficulty falling asleep, there's evidence that other things that we can do, like changing the environment or changing behavior, can remedy that sleep problem. And so we can remove that medicine quite easily. With a major depressive disorder, it's not as simple with some of the other non-drug measures to manage the mood disorder. And so usually there is more benefit, there's risk, but there's also more benefit with using something like an antidepressant, or if someone has psychotic symptoms, an antipsychotic can't easily be replaced sometimes with other non-drug measures. And we also see other harms associated with some of the sleeping medications. So they also affect cognition or increase risk potentially for dementia in the future. And we don't see that with many of the antidepressants. So overall, the safety may be a bit better with some of these other classes, and it's difficult to replace them, whereas sleeping pills can maybe be more easily replaced. But I'm happy to hear other comments from Pam and Denise as well.
Cheryl, I think you're quite right. There is that happy balance But I think what we all need to remember is, like you had mentioned, as we get older, medication processing, does change as we age. So I think there's always opportunity to make sure that there's always a regular review. Is the dose appropriate at that point? Can it be, reduced? Even with depression, depending on how severe the original, the state was, there could be an opportunity to try deprescribing, and there are guidelines that do direct that. So that's why I think when you do see those medications on a patient's list, it's good to start those conversations, bring it up. Have they thought about it? Have they discussed it with their primary care provider? Because like we had said, sometimes they don't even know they should be asking. Sometimes they just assume that they should be on them forever, and that may not always be the case.
Awesome, thank you. So we do have one question unanswered, and if anyone has any final questions that have come to mind, please put them in the Q&A while I read off this last question. And it says, hello, I am a registered nurse that works on an acute medicine unit in a hospital in Winnipeg. I find that many of my older patients have a hard time sleeping in the hospital and often have associated anxiety. I find that my first instinct is to give a PRN medication like, sorry, I'm not a pharmacist, but Zopiclone or benzodiazepines. I have witnessed falls overnight related to confusion and dizziness from these medications. Is there an alternative intervention or medication I can utilize to decrease the risk of falls? Thank you.
So I can speak briefly to this. The majority of my work takes place in communities and then previously in long-term care. So I'm not as familiar with the acute care sector. But in regards to better sleep, I mean, physical activity helps people sleep better. My mother is 76 and she manages multiple chronic conditions and had great difficulty for many, many years in falling asleep. She would usually have a nightcap, but of course we know that while alcohol can cause sleepiness at first, it's followed by wakefulness. And so I ended up buying her one of those stationary pedal machines, and now she uses it nightly when she watches the news and falls asleep, no problem. So if possible, perhaps involving recreation therapy around exercise. And I'll pass it over to my colleagues. I'm sure they're more familiar with the acute care sector, but I do think that, alternative interventions to medications are really important and should probably be our first choice, but I can understand with staffing issues and resources that that's often not as easily supported. I'd also quickly like to give a shout out to Joanna Trimble. Joanna, thank you so much for all of your comments throughout this presentation. I'm continually impressed by the level of expertise that's not only among the presenters, but among the chat at these Loop presentations. Thank you for helping round out the resources that I shared from BC. I follow your research. So again, a big thank you to the folks in the chat and then also my co-presenters.
Cheryl, I can't tell whether you wanted to chime in on that question, but from my perspective with my inpatient experience, I think one is setting the expectations from patients that medications and the environment is not going to change. So, letting them know that sleep is never going to be good in a hospital situation because it's just not your bed and there's lots of loud noises, and that adding a medication could worsen things. So I think being quite clear about that. Also making sure that staffing give the same kind of messaging as well, that medications should not be the first go-to and that they are a last resort, whereas sometimes I find that that's the first thing they reach to just because it's easiest. And last but not least, I think if you are going to, use them because you have no other choice, use the lowest effective doses that you possibly can. So cut that thing as small as you possibly can. And also set the expectation that this is not something you're going to prescribe on an outpatient basis, because that's the other problem that we do tend to see, that those transitions of care, that those medications unfortunately get continued and then, end up being those chronic problems out in the community as well. And I'm noticing that everyone's chiming in about using earplugs. Absolutely. Find out what's really keeping them awake, instead of just thinking that it's just anxieties or things like that too.
Yeah, I was just going to add that online, many of the resources that we're sharing were first tested in the community, not in hospitals, but there is some evidence as well, which could be another presentation in the future about deprescribing in hospital. There is research coming out that we are able to make those changes. And so some of the interventions that people are describing in changing the environment or changing their behavior is shown to be effective at reducing the number of medicines. So I think it takes a little bit more creativity in listening, because often the people in the bed, the patients who are in hospital, have some of their own suggestions for what might be impacting their sleep and their own suggestions for what could be improved.
Great, thank you, ladies. We do have one last question that came in, and I'll opt to answer it here on the recording, so we don't create a whole written document with one last question. So our MVP, Joanna, she says counseling and psychotherapy are not usually covered well by the health plan, but if you're older, meds are covered. So other treatments that are non-drug don't get used. Just wondering if anyone has any comments about that.
Agreed, Joanna. And fortunately, we have advocates like yourself and various experts and researchers trying to advocate for this change. It does reflect partly the culture that we've had, that medications are easily accessible, but sometimes far more harmful. So I think there's quite a bit more advocacy to be done. And the evidence does support that some of the things you're describing here, such as counseling or psychotherapy or cognitive behavioral therapy, is when compared to medicine, is actually more effective. So worth the investment. So I think we have more to do in terms of advocacy there.
Great, thank you. Alrighty, well, I will say one last thank you to everyone who participated today. Again, thank you to all of the activity in the chat. It's like Denise said, it really rounded out the presentation, and it's a great example of the Loop community and how it's foremost a space to share knowledge with each other. And a huge thank you again to Denise, Pam, and Cheryl for such a wonderful presentation, incredible answers to those questions, again, showing all of your expertise and all the applicability of your knowledge. So I thank you again. I hope everyone has a great rest of the day, and we'll see you again soon. Have a great day, everyone.